So I think we're going to start. Thank you very much, everyone, for coming to our Innovative Discovery series. Welcome. So we are delighted today to have Dr. Grant from the Coalition to Transform Advanced Care, or CTAC, to talk to us about improving palliative care. So before I introduce our speaker, let me go over some housekeeping issues. Please make sure that you sign in and please RSVP so that we can better prepare for the next session. And you need to text 218 on your cell phone for the CME attendance and for any CME credit. The ID series will return in 2017 on January 20th with primary non-adherence, lessons learned through linked pharmacy claims presented by our own Dominic Comer. And please visit the ACCEL website at DE-CTR.org for the full schedule and recordings of previous presentations. So as I said, we are absolutely delighted to have Marianne Grant here giving us a talk. Dr. Grant is currently the Director of Policy and Professional Engagement at the Coalition to Transform Advanced Care in Washington. She's also a nurse practitioner in the Palliative Medicine Service at University of Maryland and an adjunct associate professor at University of Maryland School of Nursing, as well as adjunct professor at Johns Hopkins University School of Nursing. In 2015, she was a fellow at the Center for Medicare and Medicaid Innovation, and this was funded by a Robert Wood Johnson Foundation Health Fellowship. Prior to that, she was also faculty at University of Maryland School of Nursing and also was project director of the Living Kidney Donor National Institute of Nursing Research for the tailored end-of-life decision-making pilot study at Johns Hopkins, in which I'm very interested, obviously. She has received multiple awards, and I mentioned already the Robert Wood Johnson Foundation Fellowship, and she's a leader in multiple professional associations at national and state level. One of them, she's a member at the Institute of Medicine of the Evidence Communication Innovation Collaborative Group, and as well as a member in Maryland of the Maryland State Advisory Council on Qualitative Care at the End of Life. She has numerous publications, both in peer-reviewed, but also in blogs, newsletters, letters to editors, and prestigious journals such as the New York Times, and even they had an iPad. You need to tell us about that, about quality of life, and an app. Sorry, not an app, an app for an iPad or iPhone about quality of life in the context of pancreatic center. So thank you again and welcome.
Well, thank you so much for having me, and thank you so much for coming out on this chilly day. I hope that the soup is still warm. I already kind of had some while it was freshly delivered. This sounds like a wonderful lecture series that you have here, and I'm honored to be here. Let me just ask about the audience. So how many of you are clinicians? Let's start with that. Okay, a few. And how many of you are researchers, which doesn't mean one or the other? Okay. And what are the other categories, Sarah Faye? Some of you are administrative. Great.
Data folks.
You're keeping the lights on and things running. So when Sarah Faye contacted me and said, can you talk about innovation? I said, yes, I can. I'm happy to talk to you today about innovative ways to improve the care of those with advanced illness, and I'm going to explain that in a moment. So my objectives are, we're going to talk a little bit about what advanced illness is. That's not going to be a shock to any of you. And talk a little bit about the problems, or I guess the opportunities, to improve the care of those with advanced illness. Then I'm going to spend a section talking about palliative care and hint. That is one of the innovative ways to provide care to people with advanced illness. And then I'm going to talk a little bit about some of the new clinical and payment models that are coming out of healthcare reform. That's a lot of what I spend my time currently doing, and how there's an opportunity to improve the care for those with advanced illness by incorporating palliative care. So as she gave you my background, I thought I would just revise, go over the highlights. So I am both an acute care and a palliative care hospice nurse practitioner. which when you think about it, that's kind of an interesting combination. There aren't a lot of us with that dual certification, and I do see patients a few times a month at the University of Maryland Medical Center on their palliative care consult service. I saw patients on Monday. Always an enlightening experience because, you know, in Washington, we're flying along at the 30,000-foot level, and then you're in the hospital and you're on the EHR, and you're like, oh yes, that's what we're talking about. I also am faculty at the University of Maryland at the School of Nursing, and I did this really wonderful Robert Wood Johnson Health Policy Fellowship. Now, there are a number of health policy fellowships in Washington, but this is a pretty good one. It was a full-time experience for a year and a half, and I was actually a staff member in Nancy Pelosi's office for 9 months, working on what became the MACRA legislation, and I'll talk about that later on. And then I did spend time at the Medicare Center for Innovation working on their hospice demonstration project. And when that was all said and done, I kind of couldn't go back to my academic situation, so I was lured into staying 3 days a week in Washington to do health policy. And I think as a clinician in the health policy world in Washington, it's really a cool combination because you know, clinicians speak with an authority that policy people typically don't have. And so when I talk to somebody in Congress or somebody at Medicare about what it's really like to care for patients nowadays or, you know, at the moment, I think people are inclined to listen to what I'm saying. So I'm at the Coalition to Transform Advanced Care, or CTAC, that's what the slides say. Just a little background on that. So this is a not-for-profit, nonpartisan coalition. We have about 140 national and regional members, and they span the gamut of everything regarding the care of advanced illness. So we have payers, we have health systems, we have professional associations, we have patient and consumer advocacy groups, all working together to try to make things better. And we are located in Washington, so we are known within the world of advanced illness or palliative care for our policy expertise. And here's the definition that we use for advanced illness. I don't know that there's an official definition yet in Washington, but we would say that it's when one or more of medical conditions gets to the point where several things happen. First of all, overall health and function begin to decline. So this is stage 4 cancer. This is stage 3 and 4 heart failure. This is the last stage of COPD. And when patients get into that situation, treatment doesn't always lead anymore to what they were hoping it would lead towards. So if you have cancer, this is likely not curable anymore. If you have COPD, we're making the best of a bad situation. And for that reason, a number of patients start to question whether conventional treatment, medical treatment is really what they want to be doing, and maybe they should be shifting. They should be shifting to add palliative care, or maybe they're even considering hospice. Now, this is CTAC's goal, and I have to say this is my personal goal as well, and I think it's a pretty good one. And that is that all Americans with advanced illness, but especially the sickest and most vulnerable, should receive comprehensive, high-quality, person- and family-centered care that is consistent with their goals and values and honors their dignity. And I am personally committed to spending the rest of my professional career trying to see if we can make progress on this. And why are we even talking about how we have to improve this kind of care? Well, we know, and there's a fair amount of research now that confirms that there is a number of big gaps. People would like to be at home with their families in the last part of their lives, but the clinicians in the room will know that unfortunately they spend way too much time with us. Many of them are in and out of the hospital, they're in and out of doctors' offices, and unfortunately things aren't getting necessarily better with their health, so they're spending a lot of time in a place where it's not their first choice. They would like, oddly enough, to have their pain managed and other symptoms managed. And I would like to say that now that we've made it the 5th vital sign in the hospital, that this always happens. But it doesn't always happen. So I was an ICU nurse, and I know that a lot of the things we did to try to save people were very physically uncomfortable. And that was worth doing if the person was either going to be saved or wanted to be saved, but less appealing to do if neither was the case. People tell us again and again that they would like to have their spiritual needs addressed. Spirituality is important to almost all people. Religion is important to many. And that is a very important source of comfort for people when they are in the last stages of an advanced illness. And yet that is something we almost never talk about in a medical situation. I do as a palliative care person, but I think the average clinician doesn't. And it's a bit another disconnect. And then the last area is that most patients' biggest wish is that they not burden their families. And they certainly don't want to impoverish them. They don't want people to be in financial straits because they got care. And yet we know that unfortunately the out-of-pocket cost for illness can be high, and it also is expensive to society. So again, it's not that we shouldn't spend the money, it's how we're spending the money. So that brings me to one potential solution to the situation, and that's something called palliative care. And I would imagine that you have palliative care here at Christiana. So this is a definition that was tested with the public. I use this definition whenever I can because when people hear this definition, almost every one of them says, that sounds pretty good. I would like that. So it's specialized medical care for people with a serious or advanced illness. And the goal of all of it is to improve the quality of life, but not just for the person with the illness, but also for their family. Because illness isn't something that just happens to the person, it also affects their loved ones. Palliative care is typically provided by a team, and that team has physicians, nurses, other specialists, and they work with the patient's other providers to provide what we call an extra layer of support. And that phrase is of particular appeal to people going through a serious illness. Now, the other good news about palliative care is that it is appropriate at any age or any stage in an illness. And that's because it can be provided concurrent with curative or disease-modifying treatment. Now, some of you might be thinking, Marian, if that's what palliative care is, what's hospice? And I'm so glad you asked that question. So hospice is that form of palliative care for people at the end of life. Said another way, hospice is a form of palliative care, but not all palliative care is hospice. And I make this point because many of the people that I see in the hospital equate the two and tell me, we're not ready yet. These are the patients who often die in the next week, so that's a whole separate issue. But it's not just for dying patients. And here is a Venn diagram that I actually got published in a cancer journal. So it's a profound illustration, isn't it? You get the idea. Now, the deal about hospice is that you need a prognosis of less than 6 months. How did the government arrive at that? Well, now that I'm in Washington, I have met the people who worked on the hospice Medicare benefit, and their story is it was originally a year before death. And then they looked at the cost of it, and the cost was too high, and somebody said, okay, we're just going to whack it down in the middle. So that's the evidence-based reason that we torture patients and make them wait until 6 months. Now, are we good as a field at prognosticating 6 months out? No, we are not. We are very good a week out from death, which is unfortunately when 30% of patients get hospice, but we're not so great about the 6 months. And here's the other thing that's a problem with hospice. Most people have to give up disease-modifying treatments. So if you're a leukemia patient who's requiring transfusions to stay alive, many hospices will tell you you have to stop that. Now that is a really bad deal breaker. I'm a second career nurse. Before I went into nursing, I had a career in marketing and advertising. And even though I'm a good salesperson for hospice, even I can't talk people into giving stuff up. And the demonstration model that I worked on at the Center for Medicare Innovation was trying to allow hospice patients to continue to get things like palliative chemo, thoracentesis, paracentesis, whatever they needed in addition to hospice care. That's just started. It's going to take us another 3 or 4 years to know whether that worked. But actually, a number of private industry and private payers are offering both, and that's found to be very, very beneficial. And so when you think about focusing on quality of life, it's more than just the physical aspects. So if you think about somebody you might know who has a serious or an advanced illness, maybe they are not physically uncomfortable, but maybe they're worried. Maybe they have existential concerns. Why did this happen to me? What's going to happen next? What is their life after death? Maybe they're depressed over their illness, or they're anxious because advanced illness is often very uncertain. And their roles have changed. So it's not just working on physical symptoms and keeping people physically comfortable. It's recognizing that there are issues in all these domains and being comfortable talking in all of these domains. And here is the vision of the world that the palliative care field would nominate to you all. And that is that even at the very beginning of an illness, you might consider that some patient has palliative care needs. A lot of people, I worked, the iPad app, I did research with pancreatic cancer with the Center for Pancreatic Cancer at Hopkins. And people find out about pancreatic cancer late in the game because they have symptoms. So they want to do everything they can, many of them, to fight the cancer, but they're already having issues, and they've gotten a really bad news. So palliative care could be part of the care from the very beginning. Over time, since most people in the United States die of chronic illnesses which we cannot yet cure, right? Think about it. Heart failure, diabetes, COPD, stop me when when you're tired. That we have less and less to offer medically, and we have maybe more and more from a palliative care standpoint. Hospice is something that could certainly happen in the last part and maybe for longer than the week that 30% of hospice patients get it. And then after that, there would be death and bereavement care for their families. So that's the vision of what we're trying to do. And a little evidence to support that palliative care doesn't just sound like a good idea, but actually is effective. So multiple benefits, particularly for oncology patients. That is the population that has most of the research on palliative care has been done. And some of the studies show that patients live longer with palliative care. So now there's an intriguing idea. So you get to have your cake and eat it too. You get all the palliative curative stuff. You get palliative care on top of it. You might actually have a better outcome. None of the studies show that you live less long. So that is a fear people have and say, well, that's giving up. No, actually, it's getting resources to do better. Definitely does improve the quality of life for people and their families. Certainly improves communication and people's understanding of what their goals and their values are. And I'm going to say more about that later. And then, fortunately, consistent savings in the hospital particularly, but new data that shows that it's also true in the community. And here's the citation for that review if you want to go see it. Now, let me talk a little bit about the hospital cost savings, because people are like, you're adding something on and it saves money. How could that be? Well, interestingly, it saved in this study in New York State about $7,000 less than just usual care alone. And that's because people who got palliative care in the hospital spent less time in the ICU, which is the most expensive place to be in the hospital. They were less likely to die in the ICU, so it was possible to move them out of the ICU either elsewhere in the hospital or ideally home to hospice, and they were more likely to get hospice referrals. Now, just to clarify for those of you not familiar with palliative care, these results are not because somebody like me comes in and talks people out of being in the ICU or whatever it is that they want. What we now know from repeated research is that when we talk to patients and they really come to have a full understanding of what their medical situation is, we lay out the options for them, including the non-aggressive, non-curative ones, and we make them sound just as valid, that many people opt for the less aggressive approach. Or they start down the aggressive path and then they say, you know what, this isn't working out for me. And the result is that they are not in the hospital, they're in hospice sooner, which tends to be less expensive, and everyone saves money and they have a better experience. When I see patients, I am there as a neutral advocate. If you want to go down guns blazing, you want to be hooked up to every machine man has to offer, you are in the right hospital where I practice. We have 1 million machines, and I'm happy to advocate for that person. But many patients don't want that. But a lot of times we don't know that because we don't ask that question early enough. And here's a citation for this study. Here's another interesting fact that wasn't valuable up until a few years ago. It reduces readmission. Now, that is probably because when you see somebody from palliative care, we do spend time addressing what the social issues are, what the emotional issues are, and we end up crafting a plan for the person going home that addresses those things. Many times they do go home with hospice, and we know once people have hospice, almost all of them are very happy with it, and they tend not to come back to the hospital. So multiple studies say that this is helpful for that. So now I'm going to shift into my new life, which is being a policy wonk in Washington, which was a lot of fun until the election, and now things are really kind of up in the air. The days go by and we're like, who's in charge, and what are they going to do, and what's going to happen to things like the Affordable Care Act, and when is that going to happen? So it's really kind of interesting. But what is going to continue regardless of who is president and who is running Congress is that we are definitely shifting from a fee-for-service world where we got paid for doing stuff to being paid for value, where we get paid for outcomes. Now, the fee-for-service payment system it was very simple, right? It made sense. If you did a gallbladder operation, you charged a certain amount, and if you did 5 gallbladder operations, you got that times 5. Everyone could anticipate revenue. It made a lot of sense. But unfortunately, it might have had the consequence of encouraging us to do more stuff than less because we got paid for more stuff. And duplicating test results wasn't up until recently a problem because we got paid for those duplicate results. Now the shift is recognizing that that is not maybe in the best interest of both the patients and from a financial standpoint, and now we're shifting to this value focus. We are also shifting from being medicine-centered to being person-centered. And one of my colleagues describes this as that moment when Copernicus discovered that the Earth was not the center of the universe, of our, universe, that it was the sun. And so if you think about it, we have built a system that is focused on the temples of our medical care, right? Patients come to us. If we build it, they will come. Well, now we're recognizing that really they would rather not be in those temples so much, and now we need to go to where they are, and care is shifting out into the community. And I think these developments are wonderful for palliative care because up until recently we didn't really have a good way to pay for this, and we didn't have a lot of interest in this focus on person-centered care. And the greatest news for palliative care is that it delivers all 3 of the triple aims that you hear about for health reform. And that is that we're trying to improve the health of populations, we're trying to improve the quality of care, and we're trying to control costs. And there you are, palliative care delivers all 3. If you talk about the quadruple aims and you add clinician satisfaction as the 4th aim, palliative care helps with that as well. So sometimes you hear people talk about the quadruple. All right, I'm going to talk a little bit about new payment models. Bet you didn't expect that today. And I'm going to show how palliative care could be linked to them. So now there's a lot of alphabet stuff out there. You might all know this, but I'm just covering this because in case you don't. So ACOs, accountable care organizations, what are those? Well, it's a group, usually of physicians, but often hospitals or other healthcare providers. They get together in a group, and it can be a formal, group, as in it's a clinician practice, or it can be an informal grouping. And they commit to delivering coordinated, high-quality care for Medicare patients. Now, ACOs work for other patients too, but this is a Medicare device. And the idea is that the coordinated care is supposed to deliver the right care at the right time and avoid that unnecessary duplication of effort and test results, and ideally prevent medical errors because things are kind of coordinated. Now, the reason this is a payment model is because if the ACO is successful in coordinating and delivering high quality care, and they spend the health dollars more wisely, they get to share in the savings that Medicare would experience. Now, how is that calculated? Well, now this is where it gets really complicated. So the ACO has a patient panel. Medicare looks at a matched panel that's getting usual care and see what their spending is, and they look at what the ACO spending is, and the difference is the savings, and the ACO gets to keep some of those savings. So pretty interesting idea. Now, these have been around for 3 or 4 years. Their results are kind of mixed. There are a few that have been enormously successful, others that have not been so successful. Another new payment model is the patient-centered medical home. And this is the idea that we take primary care and we make it the central point and try to coordinate and make things more comprehensive and high quality and accessible through that central point. Now, this is interesting for people with advanced illness because traditionally they are seen by multiple specialists. So my 90-year-old mother has 5 serious health issues and she's seen by 5 specialists, none of whom talk with one another, none of whom share an electronic health record, and her primary care physician, who is a lovely person, is not in touch with them either. So she has a med list of 20 medicines. Somebody added 2 last week, and I'm like, oh my God, do they not talk with one another? Anyway, so the idea is that in the patient-centered medical home model, everything is controlled through the primary care provider and office. So we have these new models. Well, how do they relate to palliative care? Well, interesting. As I said, the ACOs particularly so far, they've been okay at reducing inefficient spending and coordinating care. But there was just recently an article in last week's New England Journal of Medicine that says, hey guys, care coordination, it's not going to be enough. It's not enough cost savings, all right? And I would say, and people in my palliative care field would say, that's because they have not really adopted the full person-centered approach. Because those ACOs and payment models that have shown not only reduced cost and utilization, but they have shown higher use of hospice and for longer, and they have shown higher patient, family, and provider satisfaction and better patient outcomes. And if you put the patient in the center and you develop a medical plan around their goals, that's where the real savings is, and that's where the real satisfaction is. Here's an example of palliative care that is being delivered in an accountable care organization. So this is ProHealth. They're a multi-specialty physician practice in the greater New York area, so not far from here. The population they care for is, fortunately for this presentation, also advanced illness. They are providing home-based palliative care services, and they are using nurses and social work in addition to physicians. So again, going back to the idea of quality of life being multidimensional, they're not just sending medical resources into the home, they're sending these other resources as well. And they do a combination of home visits and telephone follow-up. And they're finding that the telephone follow-up is working. Once a relationship is established, people are fine as long as they have somebody that they can call in the middle of the night that knows who they are. The results from this experience are significant cost savings because of, again, the same thing, fewer hospitalizations, definitely increased hospice use in the final month. And I've given you the citation. This was just published in the recent Journal of Palliative Medicine as the study results for this accountable care organization. So looking very promising. There are also examples of palliative care integrated into primary care. Northwell is an integrated health system, and they are using an independence at home model. And this is not only patient-centered primary care medical home, this is primary care in the home. They deliver all their care. The doctors, the nurses, the technicians go to the house, which is a really intriguing model that has shown some mixed results, but overall looking very promising. Their population is also advanced illness, but also complex care and stable chronic conditions. So a little bit of a broader definition. Again, a defined palliative care bundle of services delivered telephonically and via team-based home visits. And I think this is the combination we're going to see moving forward. This seems to work. And it's also cost effective. And their results, again, improvement in care effectiveness, efficiency, patient experience, reduced utilization. And there's the citation where you can get more information on that. All right, that brings me to MACRA. How many people in the room know what I mean when I say MACRA? All right, all right. All right, so for the rest of you, why do you care? Okay, so this is the Medicare and CHIP, or Children's Health Insurance Program Reauthorization Act. I will tell you a funny story about this act. This repealed the previous sustainable growth rate, and that was the method we calculated year to year how providers were going to be paid for Medicare patients. So when I did my fellowship, I started in the fall of 2014, the Health Policy Fellowship, and they talked a lot about the SGR at that time, the sustainable growth rate. And I said to myself, I am not going to really pay attention to this because I don't think I'm going to need to know this. What made me think that, I don't know. This was not an area of health policy I was drawn to. I thought I would do something in palliative care I wouldn't need to know. All right, I get into Nancy Pelosi's office. I'm there a month. I notice secret negotiations are going on between her office with my boss and Boehner's office. And I am sitting in on meetings where they're like sneaking us up the back stairs in the Capitol, because we are working on getting rid of the sustainable of the SGR, and we are working on this thing that subsequently was called MACRA. So needless to say, I had to learn a whole lot about it. Okay, we got through the legislation, it passed in the House and then in the Senate unanimously, which means it's not going to be repealed by the new administration and the new Congress. And then I got into the policy job, and I thought, okay, well, that's it for me in MACRA. No, it wasn't, because the rule was published last summer, and now we had to go through the rule and say, okay, is this going to make sense for people with advanced illness? So now I know a great deal about MACRA, and I'm not going to inflict that on you. The thing about MACRA is that it is starting in 2 weeks. And it's less important for those of us who practice in the hospital because we don't bill directly, but it is very important to everybody outside the hospital if you're a healthcare provider, because this is how you are going to get paid. Now, they were going to just shift to it, but then the recognition was that this was too big a change. So now there are intermediate options and phase-in options. So we're moving there, but we're going to move there more slowly. And there are going to be two payment systems, one called MIPS, which is the Merit-Based Incentive Payment Program, and then this alternate payment models thing. So let me talk a little bit about MIPS, and this was a long preamble to my palliative care talk, but look what the areas are that you're going to be paid on in MIPS. So forget fee-for-service, now you're going to be paid on a combination of patient outcomes. Oh my, that hasn't been part of the equation yet. How good your IT systems are and how well they coordinate the care. Quality improvement is encouraged, and also cost control. Now, cost control is a small factor, but it is a factor. And again, what it would help you with all of those things? Maybe palliative care as an approach would help with all of those things. Certainly would improve outcomes, quality of care, and help you with cost. The other payment method, the alternate payment models, very technical. This is going to be validated new models that are going to be identified by Medicare. They're just standing up that process right now. So those practices and those providers won't report on MIPS. They'll report under their new payment model. But the concept is still the same. And I would say that incorporating palliative care would help with being reimbursed for these new models as well. So palliative care is now a field that's about 20 years old. It started in the hospital. It was initially in the hospital as a consultation service. And the problem with that is that most people who train, of course, train in the hospital, and so they think palliative care is just in the hospital. And of course, in the hospital, I'm typically called to see dying patients, like actively dying patients. So many of you will think, oh, that's what palliative care does, because that's who I call them about. But that is really not the case, and yet that in the hospital, we at least have to see those people. But we're expanding. Many hospitals are adding inpatient units, outpatient clinics, again, following the patients out of the hospital, keeping them out of the hospital in the community. And now there is a whole movement afoot to do home and community-based palliative care. There are for-profit companies that are hot on the trail of doing this, and some of them are doing a really fine job, and they're locking up this kind of thing. So very interesting shift in this direction. And I think, palliative care needs to be wherever people with advanced illness are. And if they would like to be in their homes and in their communities, we need to meet them there. Okay, but how are we going to do that? So up until now, we've relied on specialists like myself. I love it when I get a call from the team, Marion, come and break bad news to my patient. I'm like, okay, I will go with you while you break that bad news. I will come after you break that bad news, but I am not breaking that bad news for you. That is still your role. I will help you do that. But that gets into this whole topic of primary versus specialty palliative care. And I don't know if this is something that people outside of the field are familiar with, but so if you think about who are the specialists, well, it's those who went through a palliative care fellowship or board certified. I'm board certified as a nurse practitioner. And obviously, in an ideal world, we would handle the most complicated patients, right? Because there are some patients where either the family dynamics or the symptom management or the combination of both really calls for a lot of expertise. But much of it could be handled by what we're now calling primary palliative care. And that is that all clinicians would have basic palliative care skills, and they would integrate that into whatever practice they had. Now, this is very similar to cardiology, right? So as an acute care nurse practitioner, I was trained to handle basic cardiac issues. I know what to do when there's, somebody's having acute coronary syndrome. I know what to do with heart failure. I know what to do with, most basic things. But when it starts getting tricky, I call a cardiologist. And all of us do that, right? So we have to have a little bit of expertise, but there are experts there to back us up. So what would the skills be that all clinicians would ideally need to, gain to be able to do primary palliative care? Well, first of all, symptom assessment and management. I think what we're seeing with the opioid epidemic is that maybe we weren't really so good at pain management, because you can't just throw opioids at patients and expect that that's all going to work out. So it's a little bit more complicated than that, but it is easily learnable. Communication is a big part of what I do. I think this is the heart of palliative care. It's having those tough conversations, working with patients to really understand what they want, helping them understand what their situation is, and going forward with a plan of care. Psychosocial support. This is something that for social workers and nurses is not such a stretch. That's part of our training as a discipline, but we know that for other disciplines, that's like pharmacy, that's maybe not part of their training, and yet we are encouraging it to be. Because, a lot of times people come back to the hospital not for medical reasons, right? But because there were social reasons. They couldn't get transportation, they weren't taking their medications right, weren't getting proper nutrition. Spiritual support, as I said earlier, kind of important to many of our patients and something we all need to be more comfortable with. And then finally, certainly, care coordination. All right, how could you get these skills? Well, the good news is there are a number of really terrific training vehicles. So EPIC is training for physicians, ELNEC is training for nurses. I am an international ELNEC trainer. I have taught ELNEC in Kazakhstan and Kyrgyzstan. I was doing the K countries for a while. But I have taught ELNEC. We've had physicians sit in on ELNEC trainings. CAPCE is the Center to Advanced Palliative Care. They have amazing online resources. A lot of them are CME, and if you are working at a facility that is a CAPCE member, you have access to them. And then CSU is the California State University that has just decided, we're going to do this all online. And they offer a number of training programs to people online. So that's great for overall, but if I could start somewhere with most clinicians, I would start with communication. And again, we have some really encouraging bright lights. So Respecting Choices is a program out of Gunderson that is the advanced care planning process. So effective that 96% of people in La Crosse, Wisconsin have advanced directives. And so people say, okay, yeah, but that's one town in Wisconsin, give me a break. It's probably a pretty homogeneous place. No, they actually have data that say other communities have been able to significantly ramp up advanced care planning using this process. And this is something that you can get training for your institution through Respecting Choices. Vital Talk is a program that used to be called OncoTalk, that was a research-funded thing for oncology fellows that decided a year ago it's going to take us forever to do it as a research project, to 10 fellows at a time. And now that link will take you straight to all of their training materials. Amazing videos. You can practice this at home. You can certainly watch this. You can use it with some of your students or learners and practice these skills. And then the last group is Ariadne Labs out of Harvard, and this is Atul Gawande's group. So, those of us in palliative care are not happy that it took a Harvard surgeon, of all people, to tell the country about palliative care, but he did that in his book, Being Mortal. And actually, it's fine with me because he's very articulate. He's a terrific writer. He's got an enormous media profile. You could not afford for him to be here today, so I'm kind of standing in for him, for a good old Atul. And they're working on something very interesting. He was intrigued with the whole safety checklist, this checklist idea. Now I know we're medicine people. We're not pilots. We don't follow lists. Oh, but when we do, things are better. So here are questions on their checklist, and if all clinicians could become comfortable asking these 5 questions, we would be way ahead. The first one is the question I ask every patient when I meet them. What is your understanding? What have you been told? What do you think is happening? And that is a very enlightening conversation, because I go in to see the person with metastatic pancreatic cancer, and they tell me, I had cancer, but they operated and they got it, so I'm good. Probably not. Or they speak to me in such technical language that they sound like, one of my nurse practitioner students giving me a report, and I think, oh, I can use very technical language back. The second question, what are your fears or worries for the future? Now, many patients will look at you like, duh, I don't want to die. But not all patients have that as their fear. Some of them are worried about their families. I had one patient who was worried about his soul, and he was in intractable pain. I tried aggressively with opioids to manage it. I wasn't getting anywhere. Finally, I asked enough questions. I thought, maybe this is it. We called in our chaplain. He was immediately better. He just had to confess to whatever it was. So asking what are their fears and worries, and related to that, what are their goals and priorities? Now, I think the world of oncologists, and I work with some terrific ones, but you cannot presume that every patient wants to do everything to beat their cancer. That might be true of many of them, but it is not true of all of them. And when you ask people what their goals and priorities are, you start to get some interesting information. Maybe they want to live until June to see a child graduate from college or a new baby born. So you're thinking, okay, well, I can work with that, but if you tell me you want to live 5 more years to your 50th anniversary, maybe that's an unrealistic goal. Okay, but let's talk about it. Now, here's the question none of us asked, right? What is acceptable and unacceptable? What are you willing to put up with to achieve your goal? And I got to tell you, if we had this conversation partnered with some of the cost information, so cancer patient, yes, I would like to be cured of my cancer. Okay, cancer is not curable. Okay, well, I would like to live till my grandchild's born. Okay, let's talk about this treatment regimen. Oh, and by the way, this has a high out-of-pocket cost, and you told me you were worried about your family financially. Let's talk about that before you just start taking these drugs. Or you show up at the pharmacy, and the pharmacist has to break the bad news to you that this is the copay on the thing. I never realized that pharmacists broke bad news. But I was recently made aware of this by some of my colleagues who said, hey, do you think we're happy about it, that they come in and yell at us, in the local drugstore? No. If we all asked this question, maybe you wouldn't change anything in your treatment, but I bet you would change some things. And this, I think, would get us on the road to people getting the care that they really want and that we all really want to spend the money on. And then the last question later on is, what would a good day look like? And Atul uses the example of a patient who said to him, I want to be home watching the football game. Okay, well, as a clinician, I can work with that too, right? That tells me you don't want to be in the ICU, and it tells me you want to be aware and you want to be well enough to know that there's a football game going on. All right, and you're telling me that when we get past that, life no good. All right, so we can work with that as a plan. Now, this is actually a research project. These questions are part of a serious illness care guide. And this is the link to it. I would recommend it. You can download it. It's terrific. So he's actually done research on the questions, and the clinicians will tell you this thing works. And in fact, they were successful at getting 92% of, I think it was oncologists in one of their legs of the study to have these conversations, up from something like 20%. The guide that they have is feasible, and you can use it easily. It is acceptable to both patients and clinicians, and the intervention does lead to more, earlier, and better conversations, which I think is the name of the game here. There's the link to that. And the preliminary results from a patient standpoint are anxiety and depression go down, especially when those symptoms are moderate to severe. And this builds on previous work that has been done out of Harvard that shows that when you break bad news to a person with cancer in this case, initially they become very anxious and upset. But over time, their anxiety goes down because they accommodate to that reality. Whereas the people who aren't told what their prognosis is, their anxiety actually goes up over time because they can't figure out what the heck is going on, right? No one is talking to me. I think I'm getting worse, but no one's telling me that. That's actually more anxiety provoking. These lower levels persist after the intervention. Patients think conversations are worthwhile, and they do result in concrete behavioral change. You can't ask for more out of something with 5 questions that probably, takes you maybe 10, 15 minutes to do. All right, there's the information on that. There are a bunch of terrific assessment tools for your new toolboxes as budding primary palliative care people. These come from the City of Hope. It's a treasure trove. If you go to that link, there's a million things there. But they can help you on all of these areas, especially if you feel comfortable already on symptom management, but maybe not so comfortable on spirituality. So in conclusion, I hope I've persuaded you that the evidence suggests that palliative care does improve the care of those with advanced illness. Health reform, a terrific opportunity because we're now focused on value, we're focused on quality, and reducing cost in combination with that, and palliative care is good at all of those things. And I think that if we incorporated palliative care into more of these models, they would show better results. Here is my contact information, and I've left a few minutes. Do you normally take questions? I don't know if you need a microphone to ask me a question, but I'll restate it if you want me to. I didn't lose any of you. That's good. Yes, sir.
This was a very thorough talk. Thank you. I've done just a little bit of research in this area, and one of the obstacles I've bumped up against time and again is it's great when you're in a 12-to-1 day and you can recruit a lot of people because they want to participate in this study, or Jennifer Tamil or someone like that. And it's great when you're training new clinicians and setting expectations that this is what we do. But there's a lot of ambivalence, particularly among specialists, about whether this is in fact what they want their patients. This is what their patients want. I've had specialists say back to me when I tried to do this, it damages the relationship. My colleague here, John Goodall, says, well, they're probably not doing it well. But I haven't figured out a way how to say that to them.
So they're concerned that the involvement of a palliative care person?
No, that a specialist doing a primary level of palliative care.
Oh, gosh.
So even when we've done interventions to make things very easy for them to participate in even the slightest bit, or have someone else do a little bit of the advanced care planning so we can just start that conversation.
Yeah.
There's an awful lot of resistance, and the more I've talked with these specialists about this, it's coming from a good place. It's coming out of a concern for their patients and not wanting to inflict harm. You cited some of the research about anxiety and depression. We know that people who present initially as more anxious and more depressed are much more likely to get aggressive treatment later. So I think they're sort of offering this as a way to palliate their anxiety, ironically enough.
Yeah.
So I didn't know if you had any thoughts when you're talking about a system like this one, where you have a lot of legacy ways of doing things. How would you maybe start to incorporate these tools, thinking into helping us
Yeah.
transform here.
So I think it's an excellent question, and I'll just restate it for the recording that, this is teaching these new skills. It's easy to do when you've got young learners or motivated learners, but how do you do it across, large specialty, specialists? I have had luck at Hopkins where I practice and at Maryland, the evidence is getting harder and harder to argue with. I appreciate the concern that providers have about talking about difficult things ruining the relationship, but it's just the contrary. Yeah. And the evidence says that now it has to be done well. So I mean, breaking bad news badly is not helping anyone. And so people have to recognize that they might need a little bit of skill development around this, but it actually makes for a better relationship. And I would say if you just tried those 5 questions, because there's nothing in those questions that's anything about bad news. You're not telling the person that they're about to die. You're just trying, the great thing about the questions is that they can be done by nurses, they can be done by a nurse's aide. It's nothing unique to being a provider. I think it takes the conversation to a whole new place, and it actually builds rapport with people. And and if you ask a person about what their understanding is and they tell you they don't have a good understanding, well, guys, what is informed consent if they don't really have a good, so there's evidence that suggests that up to 3/4 of people with metastatic cancer are getting treatment they think is curative when it is not. That is a ethical and potentially a legal problem, So, I work with a few diehards down in Baltimore, and I know that we might have to wait until, time passes them by. But hopefully over time, we can get more and more clinicians to be comfortable. Although a colleague of mine was in a family meeting recently with one of our top oncologists, and the family brought up hospice, and the oncologist said, well, hospice is the easy choice. And I was like, oh my God, I'm so glad I wasn't in that meeting because I don't know what I would have said back. So yes.
So we spend a lot of time here encouraging this kind of communication that you're talking about. In fact, we built into our electronic record a screen, a goals of care screen that
Lovely.
We have encouraged all of our providers to use so that any provider that touches that patient and their family can go back and review what's been done prior. The concern that I have is that if we don't do that in a coordinated fashion and everybody on the team feels feels like they can go in and say whatever they want to the patient and family along these lines, it can get
Yeah.
to be burdensome to the family, scary even, and how do you address that kind of situation?
Would that we had so many people asking these questions that was a problem. I think your goals of care prompt in the EHR, though, does raise a good question. Like, whose responsibility is that? And, patients will tell us again and again, they don't like telling their history, again and again and again. So clearly they're not going to want to have this conversation multiple times with multiple people. I'm hoping we can find a way for the EHR to help us with that so that, if that conversation has taken place, you can maybe check on it if it isn't recent. But if it was done yesterday and logged in by somebody on the team, do I need to go in and ask those questions? Now, I might go in and say, I understand you spoke to Dr. Smith yesterday and you were really concerned about X. I'm here to address that. So, do you keep track of how many patients have that screen filled out?
We do.
Yeah.
And do you report back to the providers?
We haven't gotten that far yet.
Yeah.
But
We do it.
we have a unit by unit, data of how
Yeah.
many of those screens are filled out and by who.
Just saying that it's handy sometimes to share that information so that if you have a few outliers who, just refuse to do it, you can say, the average for the department or whatever is X, and some people are at Y, But I think these are legitimate questions. I have to say, though, very few places are so advanced that this has become a problem that too many people are having these conversations. I'm happy to work on that when we get to that point. And that actually might be an interesting research opportunity, is how do you coordinate that? In a world where we go from having no one talking about these things to everyone wanting to, who is the right person? Who owns the patient in that regard? And should it even be a provider? Is this something that a social worker could do, or a chaplain, or a nurse, possibly? There were other hands. Yes?
I'm asking this question as a non-clinician who has not had medical training. Have you heard about any efforts or discussions around incorporating these kind of, education surrounding palliative care, these conversations into medical education? So I hear a lot of talking about, current providers, but starting earlier.
We all recognize that we need to get this into GME, but along with a million other things into GME. But I would have to say that I'm not a physician, but I'm aware that the field does recognize that they need to move more in a humanistic direction, that it's gotten maybe too technical, and that we need to work on basic communication skills and more person-centered. I think everyone would agree with that. It's just, what do we all think is person-centered care? Yeah. So I think we've got to approach it for new learners, existing learners, and this isn't something you do just once and you're good at and that's it. This is a skill that you have to practice over time and you get better over time with. Yes?
If you introduce this palliative care at early stage, as you propose in your slide, doesn't that sound like sometimes you basically tell the patient death row at the early stage? Psychologically, will the patient give up by themselves?
They won't if you make it sound like this is something to help them, rather than this is a choice they have to make to give something up. So a story I tell is that I had a very good friend who had, after fertility treatment, she had twins in her early 40s. It was a very wonderful thing, but she was exhausted after the twins were born, and it took us all a while to figure out that she was maybe more than just exhausted. It turned out she had a very aggressive form of lymphoma. Well, I'm a believer in hospice, but I didn't think that was the first place she should go, and so we all were very focused on getting her the best care, and she went to a big cancer center and had a stem cell transplant, which is a very grueling experience. And she was miserable. She was physically miserable. She was emotionally upset. She was away from those twins. It was awful. So she calls me, her palliative care girlfriend, and says, what do I do? And I said, hey, your cancer center has a palliative care team. Ask to see them, which she does, because she knows from me that it's not about death, that it's about quality of life for people who are living. Well, of course, her team didn't quite see it that way, but she was a pretty enlightened patient, and she insisted, and they sent the palliative care team. Well, it was pretty amazing. They got her physically comfortable. They addressed a lot of her emotional issues. They helped her register for, an absentee ballot for an important election. That was 6.5 years ago, and she's cancer-free. Now, would I say that palliative care cured her? No, but it allowed her to fully experience the curative treatment and to have a better overall outcome. So that's why I think we have to get away from thinking that palliative care is about death. It is not about death. It is about quality of life for however long the person has, and it could be years, potentially, and just focusing on making the quality of life now better. Yes?
So are there any efforts to provide this information to the public in order to avoid the whole death panel thing?
Oh my God, the death panels. Let's not even, I have a talk on the death of the death panels. Fortunately, that is behind us. This is a difficult thing. So I'm a former marketing person, and my first thought when I got into palliative care 15 years ago was that was going to be what I was going to do. I was going to do marketing to the public about palliative care. Well, first of all, it would take enormous resources that no one has yet been able to. It would take millions of dollars to do. But this message is starting to be covered in the media. So the New York Times, there are more and more articles written by perhaps aging baby boomer journalists about care for their parents, and gee, I wish she'd had palliative care because it would have been so much better. So, it's not as wonderful as having like a tobacco-free campaign that everyone heard about, but we're doing the best we can right now with media and with the field. But that's where we need to go. It's all well and good to try to push it into the health system, but it's only going to really work when patients start to come in and demand it. So for those of us who are old enough to remember when, having a birthing suite and letting the husband or the partner be there for the delivery was a provocative idea. Well, when hospitals started to do that, that became a competitive thing. And people chose the hospital they would deliver at based on what services were offered. I would love for people to approach a cancer center and say, you know what, we've heard good things about this place, but you don't have the palliative care services I need. I'm going to go over there because they do. It's probably a fantasy on my part, but I think we'll get there eventually. Well, thank you so much for, I've kept you longer. Thank you so much for your attention. Best wishes to you all.